Okay, I think we're all here. Welcome everybody. It's a little bit louder today, I think, which is always useful. And thank you. Can you hear that? Everyone hear that? Yeah? Yeah. Okay, good. Not too loud, hopefully. Okay, I just want to welcome everybody. But firstly, I should say that people that don't know me, I'm Roy Fisher. I'm the acting chair of the ICB. Some of you will know that our chair, David Florey, has moved on and is now the chairman of Liverpool University Foundation Trust Hospital. So I'm in the acting chair post until a substantive chair is brought forward, I think in the next probably 2 or 3 months. So, okay, just to make you aware of that. Particularly welcome members of the public here this afternoon as well, sorry, this morning as well, getting ahead of myself. And I don't want to single people out, but I noticed Phil Watson's here, who's a colleague of mine. I know Phil from the past. Phil used to be the chief executive of Blackburn with Darwin local authority. So welcome, Phil. It's really nice to see you. I haven't seen you for a good while, and I appreciate you attending this morning as well. So again, welcome to everybody. Okay, we have got a slightly truncated agenda this morning. It's shorter than usual. However, that doesn't mean it's not as important as normal. So we will obviously treat all these items with the due respect that they receive, and we will expect to close this meeting at 12:30. I have a number of apologies for absence. Kevin Lavery, our chief executive, is currently away on annual leave. And Sam, Deputy Chief Executive, is here with us this morning as well. Debbie Corcoran, Jeff Jolliffe, Asim Patel, Abdul Razaik and Vicky Gent are not able to be with us. Is anybody aware of any other apologies other than that? Any? Beg your pardon? David Blacklock has sent his apologies as well. Okay, thank you. Thank you, Louise. Move on then to declaration of interest. Chris Oliver, the Chief Executive of Lancashire South Cumbria Foundation Trust, has an interest in item 4, which is obviously the Blackburn with Darwin transaction programme and the transfer of the child and adult mental health and adult services. Chris is able to take part in that discussion, but he's not able to take part in the decision that we will have to make with regard to that. Are there any other declarations of interest that anyone's aware of with regard to the agenda, other than those already indicated on the record? No? Okay. So if anything does come up during those discussions, either on that particular item or any other of those items, please indicate at the time, and we can include that in the minutes to ensure that that declaration is recorded. Thank you. Okay, I think I shall move us directly on to the business items. Item 4 is the Blackburn with Darwin transaction I referred to a few moments ago. And firstly, I'm just going to bring in Sam to just comment on that, on the process. Thank you, Sam.
Thank you, Chair. Morning, everybody. Claire Richardson, our Director of Health and Care Integration for Blackburn with Darwin, will be taking us through this paper, but I just wanted to really brief the board on the sort of the process that this has been through. It has been a very robust process, and this, what we're being asked today to do, is to approve a proposal and contractual transfer of 2 services between Lancashire and South Cumbria Foundation Trust and East Lancs Hospital Trust in relation to CAMS and community services. I'm really pleased that we're talking about this today, because I think when we listen to what this is really about, it is about the many, many benefits that this will bring in line with our aims and our aspirations and ambitions as a system and as an ICB in light of patient outcomes, improved quality, great place to work and everything else, and I think we'll see that. I just wanted to make it clear today that we have, as part of that scrutiny, we have in our closed part of the board looked at the very detailed business case that sits behind this, put the scrutiny into that. We have a wide engagement that Claire will update us on in a moment. But today is the first part of this for us in terms of approving that contractual transfer. It is also subject to both Lancashire South Cumbria Board and East Lancs Board, and I think one of those, Lancashire and South Cumbria, met yesterday, I think it was, yes, to approve the transaction, and East Lancashire Hospital Trust will be on the 23rd of the month. So it's part of that whole journey, but I just wanted to make it clear that that's our remit today, and we'll be hearing from Claire now some of the detail of that and taking questions at the end. So thank you very much.
Okay, thank you, Sam. Okay, Claire, over to you. Thank you.
Thank you. So I will provide a high-level overview of the proposal and take any questions in relation to any issues board members have. So this is a proposal that aligns children and young people's mental health services across Blackburn with Darwen and East Lancashire, and adult community services for Blackburn with Darwen. It aims to improve service pathways and delivery, which will improve the experience, quality and outcomes for service users and their families. The proposals are well aligned to the ICB strategic intent and transformational ambitions of high quality, community-centric health and care, and also really well aligned to the plans for clinical reconfiguration. So this starts to set a blueprint for how we will do things going forward in relation to our wider reconfiguration of clinical services with the aim of improving outcomes and experience, because that's what this is all about. It sets out the rationale, intended benefits, risks and mitigations, including, as Sam has said, a really in-depth and intense piece of work in relation to due diligence. So we've been through a lot of questions. We've worked to the NHS England template in relation to the expectations of a community services transaction. As I say, the proposals will align community services into East Lancs Hospitals Trust and mental health services for children and young people into Lancashire Care Foundation Trust. So I'll run through a summary of the proposals, which are outlined for children and young people in section 3.1, and paying particular attention to the anticipated benefits and impact for residents. So we anticipate that there will be improved interface across physical and mental health services as a result of this transaction, but also improve pathways between children and adult services. So moving from children to adult services is often a challenge because the provision is different. This will mean that there will be a smoother pathway for those services for children and young people, but also a better interface for more specialist services such as eating disorders. It will support continuous improvement, so the learning from the current East Lancashire provision, which is deemed outstanding by Care Quality Committee, will bring and embed some learning into our provision across wider Lancs and South Cumbria. It will mean reduced variability and increased sustainability for our services. And our workforce will benefit by having increased access to specialist services and support within the Mental Health Trust. It will support our current model of horizontal integration, so our services for children and young people in relation to mental health in East Lancashire and Blackburn with Darwen have really close working relationships with paediatrics, primary care, social care, schools and voluntary sector. So we'll maintain that whilst we build this interface with our more specialist provision. And I suppose it's the first step to that wider transformation in relation to children and young people mental health services. For children and young people and families, they'll have better access and more access to help, advice and signposting when they need it. More children and young people will get into those support services earlier, and they'll get the right care from the right professional. So currently we've got children and young people on different waiting lists, accessing different services from a psychology and psychiatry perspective. This will bring it together and enable that integration. And that integration not just with NHS services, but as I've said, with those wider local government and voluntary sector services. And care will be less fragmented and more streamlined for our children and young people. It also aligns, as outlined in section 3.3, with our wider children and young people's mental health transformation priorities, so really good alignment to our strategic direction. It enables us to seize opportunities through integration. So as I've said, building our current models, that interface, children and young people don't just have a mental health issue often, they've got lots of things that affect their lives. So bringing these services together enables that coordination of care for children and young people. And in section 3.9, the table there outlines some of the wider impact for our system, for our workforce, and in relation to performance metrics. So we've really worked through what this impact will be, not just for children and families, but for our wider system. As part of the proposal, LSCFT will be putting in an integration team specifically to bring these services together as part of this transfer. And that will work on issues such as culture and workforce, retention, some of the joined up performance metrics. So there'll be a specific team that will support the services moving into Lancashire and South Cumbria Foundation Trust. But we need to be really clear that this transfer will not have a negative impact on the wider services, both provided currently through East Lancs Hospitals Trust and into Lancs and South Cumbria Foundation Trust. It will be closely monitored, so we've had a transaction board that has met fortnightly with really senior level support, so director level. We'll be developing as part of that process a benefits tracker, and we will bring any issues back through ICB exec team into both providers and through to board if required. So strong and robust assurance processes will remain, and we'll change the focus of that group as we move into the next phase. So in relation to adult community services, the current, and this is just for Blackburn with Darwen residents, the current set of services are fragmented. So historically, we've had different arrangements, some services provided by East Lancs Hospitals Trust, some services by Lancs and South Cumbria Foundations Trust, which impacts on service resilience, but also impacts on our patient residents' experience. So like CAMS, this gives us an opportunity to grow our horizontal model of care. We've got a good interface in Blackburn with our neighbourhood model and our intermediate care model in the adult social care, voluntary sector, primary care, community services, and mental health services are working really closely together. We don't want to lose that as part of this, this process. We want to build that, but we also want to build the opportunity of a stronger interface and pathway with our acute services and our more specialist services. So this should be a win-win for both adult community and for children and young people, and that will impact positively on our residents' experience and outcomes. Section 4.10 again outlines clearly the benefits for our system and our workforce and our residents in relation to the adult community proposed transfer. The finance has been challenging, so we've had challenging discussions in relation to the financial constraints. And have jointly developed a set of principles that we've worked to make sure that where possible, this is cost neutral. And we've worked really hard together to mitigate any costs, cost challenges that have arisen and the risk of any stranded costs. And brought together quite a lot of collaborative solutions. So we had an issue, for example, in relation to digital. One provider uses one system, the other provider uses another system. We've worked really hard to identify a solution, which means, again, we're putting the best digital solution into community services and maintaining the digital platform for our CAMS services. There are some risks that remain, which have been identified in sections 5.4 and 5.6, but again, working really hard to mitigate those issues. And we've identified a residual risk on both providers of around 300,000, which we've mitigated as part of the financial plan with each organisation. The full due diligence that has been undertaken, and there's a lot of information in relation to that due diligence, has been undertaken by both trusts in collaboration with the ICB and is in line with NHS England transaction guidance. It's been endorsed by finance and performance committees within both of our providers and scrutinised for assurance by ICB colleagues. That has informed the completion of our quality impact assessments and equality impact assessments, which have been approved by both David and Sarah. And we've got a robust risk register in place that's, again, a joint risk register, and the key themes for that are outlined within 6.2. As I've said, we've got a transaction board that's well attended, meets very frequently, and a number of sub-operational groups that have been making sure that the process today has been delivered on time with the right clinical and managerial leadership. We've been meeting fortnightly for escalation and assurance, and that will move after the proposed transaction, if agreed, to oversight as well. So we'll be escalating any issues. The proposed time frame is the 1st of July for both services, and as we've said, that's subject to approval by all 3 boards. The legal advice and due diligence will form the basis of the business transfer agreement, and regular updates have been provided and will continue to be provided to NHS England regional colleagues who have been assured that there is a clear rationale and patient benefits have been clearly articulated. So the final element is the enaction of the transfer, which we have had both legal and NHS England advice that we're not required to formally consult, as this is a lift and shift transaction, but recognising the benefits of improvement associated with this proposal. It will be enacted as forms of contract modification permitted under Regulation 13 of the Public Service Regulations, which came into effect on the 1st of January this year. So that's a brief overview. I'll happy to take any questions or comments.
Okay, thank you, Claire. Very clear observations there, and thank you for the papers on that. And I'm sure the rest of the board would like to join with me in thanking you and your teams and the teams from Chris's organisation in the collaborative and partnership way that you've been able to discuss these particular issues. We have discussed this before at the board, and colleagues will be aware of that. However, we did ask for this business case which you've provided us today, so again, thank you for that. So I shall now open this up to members of the board for questions, comments, and perhaps we'll come back to you, Claire, if that's okay, at the end of those remarks to see if anything you would like to add. Okay, thank you. So I'll open it.
Thank you very much, Claire. So from a local authority perspective, we are supportive of the proposals following the work that you've done to understand and mitigate the risks. That was subject to assurances that existing users of receiving providers weren't detrimented by the transfer, and it was really pleasing to hear you emphasise that point in the presentation, so thank you for that. And we would also ask, building on this work, that perhaps we explore the opportunities for our residents in West Lancashire and Blackpool to see where service provision can be improved from them with some of this learning. And I know some of that work has already been commissioned, but it would be good to see that progressed as well. And just finally, it's good to see that residents are really at the heart of our decision making, which is the most important thing. Thank you.
Thank you, Angie. Okay, a couple of other people have indicated. I've got Sheena first and then Tracy. So Sheena.
Yeah, just really wanted to echo thanks to everybody's been involved in this, and I think it's a great example of collaboration, not only between different organisations, but also with place and with communities. So I think that's going to be a really important thing going forward, is that collaboration and that co-production with all those parties. And I think will help build and help ensure that the outcomes that I think this really will bring improvements to population outcomes will bring. I think the thing that is really seen from this is the fact that this is a piece of work that's really embedded in local communities, and building out from that I think is really important as we move forward to think about how do we really start to do integration in a very effective way. Clearly that integration starts with where people live their lives in their communities, and then builds everybody working in a collaborative way as I've described around that. And clearly as we go forward as a board we want to learn from that and then see how we can apply that to other areas, and to get the best of both worlds of building that vertical and horizontal integration together, but very much centred around people and with people. The thing that I just wanted to further build on from Angie said was really just getting a sense, if we can, about what's the timetable for looking at the Blackpool work, so that as a board we don't lose that, and we've got a kind of a sense about when we might bring that back again, and keep an eye on the progress on that, so that we try and make sure that we bring those benefits to all the, the wider Langston South Cumbria footprint. Thank you.
Okay, thank you, Sheena. Tracy.
Thanks, Chair. Thanks, Claire, for that presentation. I think, kind of building on what Angie and Sheena have said, I think there's definitely a lot of support for this within the VCFSE for obvious reasons. I think it's very much about taking services much closer to people and communities. So I really welcome that. But I think for me, there's a little bit of a question mark around what does this mean practically. I just wanted to get a bit of a sense of how will this impact, because obviously this transition period will have an impact on current service users. I'm thinking about young people using the CAM service. What does it mean practically in terms of somebody who's under CAMS at the moment? Will they be able to access the service in the same way? Will they end up having to go to different places? I don't know whether Chris has got any insights he can help with as well around that, because I think those are the kind of questions that obviously we get asked by the people who use our services, because those are the significant things that they find more difficult and more challenging if things change for them. So there's that. And I think also, again, just to echo the question about Blackpool, what's the progress there as well? Thank you.
Okay, thanks, Tracy. I think I'll come back to you, Claire, on that particular item as well. And then if Chris, if you want to comment as well as also. Okay, Claire first.
Yeah, so it's really important that our children and young people and service users don't see any significant difference in relation to current service provision. So we've been really clear across all three partners, writing out to our staff in the first instance to say your caseload won't change, your base won't change, where you deliver services won't change. What will change, as we talked about, is the opportunity to integrate better. So actually what we should see is a less fragmented pathway. What we should see is children and families and adults having more of a streamlined offer, not on two sets of waiting lists, or when they're transitioning from children to adulthood, that should be a smoother process, an easier connection and interface into more specialist services. So we shouldn't see a difference in relation to what's being delivered currently. What we will see a difference in is those opportunities that I've talked about, of building improved pathways, of improving experience. We will be really clearly having conversations with current service users in relation to I suppose mitigating any concerns in the right way. So, the staff that are working with children and young people, having the right conversation with children and their families. And if there are any issues or concerns, we need to be aware of them, and we need to put things in place to mitigate that. So the clinical leadership that will be moving from LCAS East Lancs CAM services into Langston South Cumbria Foundation Trust have been leading that service for a long time. So they're really passionate about getting it right for their service users, and if they were here, they'd be very clear that anything that is less than what they're getting now will never be good enough. They only want it to improve. So I'm assured as well from those clinical leads that they're really passionate about getting it right.
Thank you, Chair. So as Claire said there, Tracy, I think, from the estates and where people access service, no change. What I think we will see quite quickly through the mobilisation and then the transformation into the rest of Lancashire and South Cumbria is that reduced waiting times, improved pathways, improved resilience around workforce, recruitment, retention. LCAS, East Lancs CAM service is outstanding, as Claire said, by the CQC. Our LSCFT's trust vision is to be the best. We want to see that LCAS service and the benefits that that's delivered to the population of East Lancs across the rest of Lancashire and South Cumbria. And I truly think that this is a legacy moment for children and young people and the wider families accessing mental health care within our ICB.
Thanks very much, Claire and Chris. I know Aaron wants to come in, but I think it's really important that the board is kept informed on progress regarding this, over the next few months. So I think, Claire, we'll be hearing back from yourself and other people on how this is progressing and, giving us confidence, I think, to be able to perhaps expand that, as Chris has alluded to other areas that aren't included already. Chris, yeah.
Sorry, it was just to come back on the Blackpool question, if that's okay, Chair. So Blackpool Teaching Hospital currently provide some children's mental health services and a small section of adult mental health services as well. And both trusts have held exec-to-exec meetings. We will continue to keep that dialogue going, working with Place and Blackpool Council going forward. So would look to bring something back within the next couple of months around discussions of where we're up to.
Helpful. Okay, Aaron, get yourself.
Thanks, Chair, and thank you, Claire. So this is a great first test, I think, of providers working together in a different way in the system, and ICB and place-based teams coming together with service users and communities at the heart of a decision to improve services largely. Now, I know Claire's just put forward a very quick summary of the work, but the amount of work that's gone into getting to this point will have thrown up issues of concern, delays, things that we haven't been able to work through quite as quickly or as easily as we'd have liked. So one of the things to reflect on as an ICB board is the distilling the learning, as well as the really good stuff that we can replicate and push out into the wider system. What are the things that might have stopped us getting here quite as quickly or as effectively as we'd like, and we should use that then to apply to further programmes that we're likely to sponsor in the future. It's always fascinating to me when we talk about transformational change or transactional change, that when we do the due diligence, we often then in the benefits put forward real step changes in things like access targets or quality of service. And I'd like us to try and find a way of tapping into that and spreading that learning and that pathway focus and that service improvement focus without the need for transactional change. And we could do that, I think, through some of the recovery and transformation work. And then the final point I make, I used the phrase earlier today, so I'll use it again in public board about being stuck and stuckness. And finances currently can create that environment where colleagues, despite it being the right thing to do, can get a bit stuck when there's a financial risk or there's a financial downside. So one of the things I know that Sam in particular you're committed to is to create a financial framework or some principles that all partners can sign up to. So when we approach these kinds of programs of work, we're doing it with eyes wide open and understanding what the principles are without the need for individual negotiations every time we want to make a change. So yeah, really good piece of work, and I think the value in it is distilling that learning that we can take into future programs, Chair.
Thank you very much, Aaron. Anybody else wish to comment or question? David, yeah.
I'll add a comment. I think Claire's introduction perhaps kind of belittles the considerable amount of work that has been done. It's really has been a journey, and I think it's important to understand it's a journey with patients, with clinicians and with the trust, because nobody likes change, but this is change for the better. This is change for which benefits patients. It's part of the direction the ICB would want to go in, where we have a one offer for all our patients across Lancashire and South Cumbria. And the clinicians were initially really quite concerned about this, and now, as Claire has said, really excited by the opportunities it gives them to work across the whole of Lancs and South Cumbria to deliver the best possible care they can. So I think this is a really excellent proposition we have in front of us. Blackpool will be a challenge as we move on to that one. The reason we started in Blackburn with Darwin, because it was probably an easier place to start. But we'd welcome to, I'm sure Chris and Claire or other, whoever it will be, we're welcome to come back to the board in the future to talk about Blackpool, but just to recommend this proposition to the board. Thank you.
Thank you, David. Colleagues will be aware that I have some experience of the Blackpool situation, and I look forward to that coming forward at appropriate time. But I do absolutely agree with the comments that have come from the board with regards to the integration of those services across the whole of Lancashire and South Cumbria. I think it really will improve the service, quite frankly, and I think it's important that we all recognise, understand that and agree with that. So, Claire, I'll come back to yourself, okay, if there's anything you want to just pick up that, or no other people have indicated, so I'll come back to you, thank you.
So I don't think we've answered the question in relation to West Lancashire and community services. There is a programme of transformation in the community across Lancs and South Cumbria, of which West Lancs will be part of that consideration, and I think probably bring something back in the autumn in relation to a recommendation, Sarah. So that's a time frame for West Lancashire, and that will be part of the wider Transforming Community Services, but also part of the place development programme. In relation, Aaron, to stuckness and stuck, finances often get in the way, but as does culture and fear of change. As I said earlier, this has got to be about how we collaborate to get the best for our residents. And I think we've got to put some of our old behaviours outside the door and start to think, how can we do this together to get the best? And I know that's often our intention, but our organisational boundaries, including finance, get in the way. So it has been a challenging process. It has been based on the right intention, but also based on strong, joined up discussions and relationships. And I'd advise the board that that is part of our foundations and principles for moving forward in relation to any configuration.
Okay, thank you, Claire. We welcome then this coming back to the board in autumn with the proposal on timescales and regarding the West Lancs issue. As I say, nobody else has indicated, so therefore the proposals are as outlined on the paper that has been circulated to the board from A to I, and that is about approving the proposals for the alignment of those community and adolescent and mental health services for Blackburn and Darwin and East Lancashire, and to approve the contractual transfer and the other items that are indicated there. Colleagues, do I have your approval for that? Is that agreed? Yes? Okay, all agreed. Thank you so much. Okay, thank you very much. And thanks again to you, Claire, and your colleagues, and to the teams that have been involved in this. Please pass on the thanks of the ICB board to those colleagues for the work that's gone on to be able to get us to this point. Okay, thank you so much. And to you, Chris, of course. Okay, we shall move on. We're on to item 5, which is month 11 finance. Sam, that's yourself. Okay, thanks.
Thank you, Chair. Yes, so what we've got in the pack is the month 11 position, but actually as we speak this week, we're finalising the month 12, the end of the year. So actually, I don't want to spend a lot of time on this paper, but probably just pull out some key messages that we're expecting to land this week in a position of around £150 million deficit after an £80 million funding receipt. So that is some way off where we started at the start of the year, but that risk has been highlighted throughout the year. There are two big drivers for that. One has been, I guess, there was a very ambitious and high-risk plan put together at the start of the year around absolutely addressing some of that unfunded capacity across the provider trust, which would be linked to recovery, and those recovery plans have taken longer to sort of embed in. But actually, the other part of the driver has been, for the ICB in particular, some significant hits on inflation, prescribing and CHC activity costs. So those things have led to sort of quite a significant deficit position at the end of this year. However, what I would like to point out is that the whole system has worked incredibly hard because the plan was very ambitious at the start of the year. We have highlighted the risk right the way through the year, and we have collectively delivered almost £240 million worth of savings, of which 70% of those have been recurrent. So without that work, we would be in a much worse position going into the next financial year. So I would like to say a big thank you to everybody that's made that happen, and it was a very tall ask at the start of the year. What's important is what we do going forward now on recovery and transformation, and that will require us to work together as a system. Maggie Oldham's now left, as we know, and she's now at Blackpool, and I've taken on the responsibility for recovery transformation. And Maggie, before she left, started some very good work around the clinical transformation. There is work going on across the provider collaborative around the shared services offer. So we are looking at how do we reduce waste and duplication, how do we work smarter, and how do we do this from a point of view of driving quality improvements through a really clear clinical strategy and clinical reconfiguration. The bit that we're going to be focusing on in terms of recovery becomes really important to drive this down as we move through this financial year, looking at the things that are going to improve quality, because if we get that right, the money will follow. So yes, there's the reduction of waste and duplication, but actually when we look at what's happening in our system around some of the things we're doing, whether it's a very high level of agency usage, whether it's sort of corridor support in hospitals, whether it's not being able to get people out quick enough out of hospital, or actually making sure that people who don't belong in hospitals don't go there in the first place, and we can avoid those sort of admissions. That's where we need to drive our recovery and transformation programme. So I will be bringing more back to the board on that, but that has to be the right thing to do, that will actually address both, you know, better outcomes for our population, but also drive the right thing for our long-term financial sustainability. I do think we're going to have quite a lot of work to do over this next year to make sure we align all that into the right place and focus on the right things first. Our place colleagues are going to be really important, and our relationships with local authority and integration agenda is going to be really key on this, because this isn't about hospitals, this is about that whole community approach. And I think if we get that right this year, what I'd like to do is stop talking about the money as much and to start talking about quality and start talking about doing the right thing, because then we can all start really doing the big changes in the system that we want to see for our population. So that's all I really wanted to say on the finance report, because I thought it's probably not helpful to go through month 11 when we're now finalising the year end. So I'm happy to take any questions.
Okay, thank you, Sam. Bringing people in one moment. Just like to agree with your comments about clinical reconfiguration, and I think the last item that we just discussed was a very good example of that and how we can embed that into the culture of the ICB. Okay, I'm going to bring in people on this particular item. I think I've got Jim first and then Aaron. Okay.
Thank you, Chairman. In one sense, this is an awful financial position. But in another sense, if we reflect on the last 12 months, we've made major steps forward in terms of the way in which the system is working together collectively, how things have generally stabilised, and they have generally stabilised, but I don't think we're deteriorating as a system now, which is not the case nationally. We've sort of collectively seemed to kept workforce at a level which is not going up, which is also pretty good. We're delivering solid savings. So I actually think, although the headline figure is disappointing, it's actually quite a good performance, and I think we should bear that in mind. But we've got major challenges ahead, as you've outlined, Sam, and it's almost like we need to note this, say it's not where we want it to be, but it's actually could have been a lot worse than this, and turn our focus to 24, 25, basically, and you talked about the recovery and transformation programme. That's going to be so important, but it feels like we're in a much better place than we were 12 months ago.
Thank you, Chair. Thank you, Sam. A very similar comment, really, which is to take some of the positive work that we've done this year into 24, 25 and beyond. So it's difficult in a standalone finance report, but generally, if you looked at our dashboards, the ICB have made some great inroads in, cost control, CHC management, medications management, providers have delivered largely big inroads into waiting lists, selective recovery, cancer diagnostics. It looks like on urgent care we are within spitting distance of achieving the national target for urgent care, despite one of the most difficult winter periods we've seen. And that's in the context of stabilising the financial position and the workforce position. So, you know, when we talk about a longer term recovery, that recovery, stabilise, transform, it definitely feels like we've laid the path here for a more positive and yet challenging 24-25. So I think as we progress as provider collaborative ICB and at this board, being really cognizant of the integrated impact on quality, safety, performance and finance, because in the main, when we make big changes to the likes of work that we've just seen on the clinical configuration, there's a triple hit on those other three elements of performance, and I think that needs to start to shape our thinking when we're prioritising key programmes of work.
Thank you, Chair. Yes, so obviously I'm here as DAS, so representing all Directors of Adult Services, but I just wanted to start first of all. So I'm actually the Director of Adult Services for Westmoreland and Furness Council, and I just wanted to say a personal thank you to yourself, Sam, and to Craig, because over the last week we've doing some close work together, and I know that you've also meeting with our Director of Finance, and I think there's plans going forward, isn't there? And I think that that's really reassuring in terms of that message about working together as a system in order to deliver better outcomes for all of our residents, whether they be patients in hospital or people living in the community. We want the best for everyone. I just think it would be remiss of me not to say from a local authority perspective, sometimes there is some nervousness in terms of when we start talking about finances and efficiencies and what maybe the NHS colleagues are planning to do. So I think it's just really emphasising that need for us to work together, and that commitment from local authorities that we are here and we are keen to work with you to deliver better outcomes and a financially sustainable future at the same time.
Okay, thank you for those comments, Kath. Well received. Is there anybody else who wishes to comment on this particular item before I go back to Sam? No? Okay.
Thank you for everyone's comments, and thank you, Kath, for that. That's very kind. I think it's really important, and I suppose you've got my full commitment, that what we can't do in this, that there could be some, we're all under a lot of pressure, aren't we, in every part of our sector financially. It's challenging. There's nobody sitting there with bags of money to spend. So it's really, really important that we get into a position where we're working in partnership over the things that we're doing, particularly recovery and transformation. There is a real risk, a high risk, that what we do is cost shunt and move money around, and we don't want to do that. So what we're looking to do is, as part of that integrated way of working and part of the recovery approach, is to agree a clear set of principles and an MOU that means that whatever we do, we're looking at this for the Lancashire and South Cumbria pound, not for how does this land in different organisations, and we have a very clear approach about how we mitigate any risk together, because the big prize here is that it's all working together. That's where we've got real opportunity. So if we move forward in a way that doesn't allow us to get past the first hurdle of moving money around, then we're going to lose that opportunity to work together. So I'm totally committed to that, and I've had some good discussions, as you say, this week that have been really helpful, and I want to continue to work with all our local authority colleagues and all of our partners in the system around that sort of principle. Thank you.
Thank you, Sam. It would be slightly remiss of me to perhaps not mention the voluntary sector as well, because I think the amount of work that's gone on with the voluntary sector has been huge across Lancashire and South Cumbria, and I think we should thank our colleagues in that sector and other colleagues in Healthwatch and who are helping us to achieve some of the outcomes that we are able to achieve around the patch. So thanks once again. And as you commented on our partners, they are part of that as well. Thank you, Sam. So this is just for noting, colleagues. Happy to note this? Yeah? Okay, thanks. Right, okay. We're over to item 6, which is specialised commissioning delegation, and the first part of that is item A, which was the Chair's action that I was able to take on your behalf. Sam, do you want to just refer to that?
Yes, thank you, Chair. So we've obviously had the public meeting today, but we're going to hear in a moment around the Specialist Commissioning Delegation and operating arrangements. There was a Chair's action that we needed to take on the 28th of March that was taken between our Chair here, myself, and supported by Craig as the Chief Operating Officer and the Company Secretary. And this was to make sure that we had in place before the 1st of April, when we started the year, that we had in place the delegation arrangements and the terms of reference agreed for the joint committee, which is a joint formal committee of all three ICBs. We had to have that in place for the 1st of April, but the paper that we're going to hear from Craig in a moment will describe what those arrangements are, and there are some other asks of this board today. So it was just to let you know that that had happened. In taking those decisions, that was also supported by a huge amount of due diligence and a working group and checklists that have been happening throughout the year to make sure that we were ready to take on the delegation of specialist commissioning. And there have been updates to the board in regard to that, but also that the Finance and Performance Committee in March received the budget information with all the risks and mitigation. So there had been some thorough review and scrutiny of the arrangements before that chairman's action was taken, and it helped us to support that action on the 28th. Thank you.
Thank you, Sam. Colleagues, are we happy to ratify that action? Yes, that agreed? Yes. Okay. Craig, move over then directly to you. Thanks.
Yeah, thank you, Chair. So just to orientate members of the board to the papers, there is a summary paper on specialised commissioning, and then in the appendix there is our joint committee terms of reference and the delegation agreement. So I'm happy to answer any questions on either the paper or any of the specifics of the appendices. In summary, though, this paper describes the background of the delegations that are coming from NHS England to Lancs and South Cumbria ICB. Just for members to note, we are the lead commissioner in the North West for specialist commissioning, and I'm the executive responsible. We've been doing a huge amount of work, and it would be remiss of me not to say thank you to Deborah Atkinson, our company secretary, and some of my specialised commissioning team who've done a massive amount of work in the background to get this ready for delegation. So that includes our safe transfer of services, the pre-delegation framework, the safe delegation checklist, in addition to a target operating model and a new collaboration agreement. So there's an enormous amount of paperwork in the background to this. So thank you to Jane and Lisa and the team who've been leading that on my behalf. As you just heard, we took Chair's action regarding our ability from the 1st of April to be able to transact that business. And what I would like out of members today is just to note the report, but to formally receive our joint committee terms of reference and make any comments, receive the delegation agreement and approve our governance arrangements. In section 6 you'll see that we've created new governance arrangements for the ICB as well, so we can manage this as well as managing it on behalf of the other two ICBs and NHS England, and that is all included in the complex set of joint decision-making arrangements under the North West Joint Committee. I know that's a lot of words for people, but it's not as simple as just transferring services from NHS England to us, which we've done previously. So I'm not going to go through the paper in great detail, but there are 59 specialist services that have now been delegated to us, and they're split between Delegation 1 and Delegation 2. And the Delegation 1 is where it's a single ICB, so those things that would just be for Lancs and South Cumbria. And then Delegation 2, which is multi-ICB, which is, to be fair, the majority of that provision. There's then a further 39 services that will be subject to further consideration for delegation. They're temporarily being retained by NHS England, which leaves another 89 services that will be out of scope, so they're not being proposed to be sent to us. The value of the services currently in scope for the North West is around 13 billion. So that's the scale and size of what we're talking about in relation to the finances. Just to give the board assurances, we have taken this through our finance committee, as the chairman said, and it's been through a number of the finance group between NHS England and the 3 ICBs with sight of our finance officers. This first year is very much viewed as a foundation year for us, so this is where we will continue to work on the operating model and how that works. Although the staff from NHS England will be aligned to myself, they are not formally transferring to us, so they're not moving employment from NHS England to the ICB until April next year. And that's to just acknowledge the amount, sheer size and scale of work that we need to do. However, the ways of working and the operating model have already implemented, so that alignment to myself and the team is really important. This has been supported by both Greater Manchester and Cheshire and Mersey ICBs, just in case there was any question of whether this was something that there might be any difference, but it's already gone through their boards. And we're the final board ready for approval for NHS England. As I said, finances have already been allocated, and we will have responsibility for those payment mechanisms, which I believe have already been agreed for the 15th of this month. I'm going to pause there, Chair, because I don't propose to go into the detail of the terms of reference and the agreement, because they are very extensive documents. However, I'm happy to answer any questions, but I think it's fair to say there's been a huge amount of due diligence, and this has been agreed internally, so seeking board support for now.
Thank you very much, Craig. Anyone who's been ever involved in specialised commissioning will know the complex issues that they have to discuss regarding that, and thank you to Craig and the team for providing us with information here today, and those particular terms of reference and the information regarding the joint committee. Okay, I'll open up. Thank you, Sheena.
So I think this is a really positive move, because if we think about how we want to try and transform services and actually thinking about the whole of the opportunity that presents in starting to think about pathways and that prevention, early intervention, I think that's really important to be able to look at that for the whole population and the majority of the spend that there is on meeting people's needs and moving towards hopefully meeting those differently. So I think it's a really positive thing. Clearly a lot of work's gone into this. The bit I just wanted to seek to understand a little bit further was around, obviously part of commissioning is about understanding the quality of services that are delivered, and clearly that will fall into the work of the ICB. So it's really just ensuring that as we move through this transition year, we understand what that means, how we're going to make sure that we have the resources particularly to do that, and how the staff that are coming, aligning from NHS England into the Northwest Hub, and and how we make sure that we've got sufficient resources and we understand how we're going to have that oversight of quality. So that was the bit really, as Chair of Quality Committee, I wanted to seek to understand. Thank you.
Thank you, Sheena. Anybody else indicated before I go back to Craig? Jim?
It's just to almost subdivide the figure Craig quoted on finance. In the report which went to the Finance and Performance Committee, it showed the amount of the total that relates to the Northwest. And the Northwest total out of the total sum of 13 billion or whatever is 1.7 billion. And Lancashire and South Cumbria's proportion is 384 million. So that's kind of the scale at which we're operating. So our budget's just over 4 billion. This is almost a 10% supplement to that, in effect.
I just wanted, in some respects, reinforce the comment made by Sheena that this is a real opportunity. Although we've worked as an ICB and a commissioned services, there's been some specialist services we haven't been able to be involved in. They're often part of a pathway, for example, cancer patients. And we are now in a position from this month where we can commission whole pathways and also, where possible, improve those pathways. So I think there's a real opportunity for us here to have all that commissioning with us in the ICB. So again, chance to make some significant improvements as we go forward. But I would agree with Sheena, we need to understand the quality issues that we inherit as well. And we have our SpecCom for their risk register.
Okay, thank you. Nobody else indicated presently, I don't think. I'll come back to you, Craig, if that's okay. Thank you.
Yes, so absolutely agree with David and Sheena on the opportunities. It's always felt challenging when you're commissioning services and then there's a part of it that goes off to be commissioned from a North West perspective to come back to local determination. So end-to-end management of that pathway and the opportunity for transformation and reform and doing things differently, I think, is a great opportunity. I'll bring Sarah in a second. The quality aspect, I think, is really important. We should not lose sight of it. I think it's fair to say, and Sarah will probably want to draw this out, there are different ways of working in relation to quality oversight at the moment. We've got to align that to ensure that it meets our standards within the ICBs, and I think that's something Sarah's team have highlighted. So I don't know if Sarah wants to come in on that, and I'll wrap up then. Thank you, Chair.
Thanks, Chair. Yeah, I think, whilst I do agree with all the comments and with David's comment that there's a massive opportunity here, so I do welcome this. I do think Sheena's question was pertinent, and I am a bit concerned, and I think as a board, because our experience from primary care delegation in housing CHC has been that actually it's not only about what we inherit, it's about we have got a role as the Commissioner to oversee and assure on the quality of these services, and we've got a very small team. We've post-frozen as part of our efficiency who will not be able to absorb that work. Complaints we'll take on eventually. I know it's not clear yet, but it's all the surrounding things, safeguarding oversight. So I think we do need to be aware that inheriting this function, there are only 3 people in the quality team at SpecCom at region who will have to continue doing the whole of the region-wide work on SpecCom. We will, with the specific services for Lancs and South Cumbria, we will inherit additional work, and it won't just be quality, there will be other supportive teams within the ICB who will get an increase in workload because we are taking in SpecCom, and I do think we need to be aware of that, and I do think it's a risk, and we have already flagged that so for instance the way the reports are done now on SpecCom I don't think would meet your standards at Quality Committee, Sheena, so straight away there's a difference there that we will have to work on to bring up to that standard. So I do think it's important for all, I welcome this and support it, that I think this will bring additional workload into the ICB, that at some point we will have to think about the capacity and how we resource that.
Yes, thank you, Chair. Sarah, I think it's a nice segue into the foundation year allows us to review what we will be receiving from specialised commissioning. I think understanding that operating model and what we want is important, and that will shape then how we see that team for the future alongside the other 2 ICBs. So I actually think having this year to work together on that will be helpful, and it'll be something that we'll take through our governance committees, Chair. Thanks to Jim for pointing out that I did give the high-level sort of national figures, but I think those 2 more local figures help, so apologies for not raising them further. And I think it would be helpful with your invitation, Chair, to make sure that our board is kept up to speed on specialised commissioning delegation, at least for the foundation year and possibly for the second year in relation to quality, performance and finance. So I would welcome an opportunity to bring that back to a further board meeting at the appropriate time.
Okay, thank you. I mean, it does slightly concern me about Sarah's comments regarding increasing workload and capacity within the organisation. It is a significant addition to our work within the ICB, and you were right to say there was, a small team there. I should probably know this, but I don't, so if somebody could answer the question, I'd be happy. Are there any programme costs actually allowable within this transfer or not?
There will be elements that relate to programme, yes.
Okay. Okay. So we need to consider that, I think, at future discussions.
Catherine Disley is our finance lead, and she's very close to this, so we can bring something back separately, Chair.
Okay, thank you. Anybody else wish to comment on this at all? No? Okay. We're then asked to approve, I think, Craig, to the actual paper and the additional appendices to that particular item.
Yeah, terms of reference and the delegation, formal approval from board if possible.
Okay, happy to approve? Agreed? Yeah. Okay, thank you. Okay, Craig, I'm afraid it's you again. We're on item 7, commissioning intentions. Thank you.
Thank you, Chair. So hopefully now board members will be familiar with our commissioning intention approach that started just before Christmas. Just to orientate members to what's in front of them, I've given a report here that is our overarching report of the Commission intentions progress to date, but also we felt it might be helpful to include our responses from our previous board sessions and how the document has been amended. As you'll see from the paper, there were a number of questions about relating to our clinical strategy, where we were looking to improve outcomes, the prioritisation of the delivery plan, ensuring that there was greater system objectives, that there was a smaller number of clear priorities. They've all been taken into consideration from the last session, and we've shaped the document, hopefully, as you'll see, differently to reflect those questions and asks from our board members. Equally, we've had a number of letters from our provider, chief executives and their teams, very much welcoming the depth and breadth of the document and the ambitious proposals, obviously wanting some more clarity on some of the detail in relation to the delivery, especially with regards to current operational pressures such as headcount and how we're going to deliver some of the step change for transformation and improvement work that's needed. And our collective need to prioritise across the partnerships the areas that we want to put the most energy and effort in to yield the best and the quickest results. We've, under section 3 of the report, we've described the actions that we're taking and where we're up to on each of those. The action that's still being developed and worked on is our integrated commissioning and delivery plan. That has been drafted and is now being populated on the basis of support from board today, and again will be shared in the open and transparent way that we've been showing the commissioning intentions to date. What we have included is now a much more succinct summary document, which is the attachment for the Commission Intentions 24-25, with a short foreword from myself, and then it walks us through the introduction to the document with the strategic context, and then those drivers in relation to our challenges for demand and capacity, and starts to then articulate where we've got real opportunities to deliver change. We still have our very detailed slide deck which outlines all of them commission intentions in the granular detail, but as there's commercial sensitivities around to them, they have not been included in the papers today. But hopefully from this new summary document, and thanks to the support of the communications team, we've started to describe here that whole vision and strategy along with our ambitions and the objectives, and how we're going to ensure that we prioritise those deliverables. So that strategy, that commissioning document now was at the front part of the original document, and now we've separated out so that this can be much more public facing. There's still work to do on making it a plan on a page for some people so they can see the highlights and the intentions, but I'm hoping from today's document you'll see the huge amount of work that's gone into finessing and finalising this into a much more succinct set of commission intentions that read to both the ICB, the system, the providers, and our partners, because I think it's important that this is not just seen as an NHS document. We've also done a piece of work to link it back to our integrated care strategy, which is the responsibility of the Integrated Care Partnership, and our provider collaborative board, who obviously is responsible for the majority of our delivery, as well as the ICB. So we've done that triangulation. I'll pause there because I'm keen to get any comments or questions on the document, but I think it's just important. We made some, I think, some really bold, ambitious statements, and just draw the board's attention under on page 8. We've started to really articulate the step change we want to see in clinical practice and quality of patient care. So our ambition is no 12-hour trolley waits. We don't want any corridor care in our emergency departments. We want no long waits for community mental health care. We want to see a reduction to those patients who do not meet medical criteria to reside to go from plus 10% to under 10% to 5% within an agreed time frame. We want to increase admission avoidance for primary care and community care. We want to reduce our ambulance conveyance appropriate for 999 calls where possible. These are all the things that we want to do that will help not only with improved outcomes for patients and quality of care and improving the patient experience at every contact, but will also support our financial position and get back to a position of stability. So, and that's just one example of the 4 or 5 big priorities that we are putting our marker in the sand on, so we can start to see some real change next year, Chair. I'm happy to take any comments or questions.
Okay, thank you, Craig. I think you mentioned ambitions and ambitious there, and about at least 3 times in those comments, and we welcome that, of course. It is a big programme, you know, and we'd like to see it delivered clearly as a board. And you indicate there that, you know, that it's a delivery plan for 3 years at the beginning of that paper. And could you perhaps indicate to us what might be delivered in the first year? I mean, I don't want you to do that now, but there will be questions in the board. But I think, you know, because of the wide-ranging, I think, comments within there about the ambitions, I think it's really important that we understand how quickly we can deliver some of those the points that you do raise within that document. Thank you. Okay, I've got just quite a few people actually. Just bear with me then. Okay, I've got Jim, Chris, Kath, Tracy and Aaron. I think it was you, Aaron, after Jim, so I'll take you after Jim. So I'll take Jim first anyway.
I'll be quick then. I think it's a fantastic piece of work. So, you know, well done to Craig and all the team. They put a huge amount of time and effort into this, but as you say, it is ambitious. It's high in commitment, but rather low in details. And we almost need to understand when we're going to get the kind of the detailed plans, the timescales, the targets, the accountabilities and so on for each of the items. But overall, I think it's a great piece of work, and it's really moved us forward, and it is consistent with our objectives, and that's important. 2 specific comments I've got on it, really. One is around the statements around primary care, about providing greater focus around, in effect, admission avoidance and dealing with the frail elderly, which in one sense is what we should be doing. But in another sense, the biggest problem we've got at the moment is people accessing primary care. And almost the last thing we've got the space to do is to refocus them on doing other things. So I'm concerned about the problems that potentially that would create. And the second point I make is around places. And whilst encouraging places to work to address local issues, there is quite a significant inconsistency between what the places are addressing, and it's the extent to which we need some degree of consistency between what's being done in the different places. So whilst we need to encourage local initiative and local developments, we also want to make sure that we're working to a consistent standard across the patch.
Thank you, Chair. Echo Jim's comments on the piece of work. That's some undertaking to get that in the shape that it is now, with that breadth of, I guess, cover across the system. A couple of reflections. One, I would agree with Jim on the what by when. So in having a document like that, it's hard now to distill the impact and the delivery plan. So an offer from the provider collaborative to work with Craig and the team to, from a provision perspective, work through what a matrix of prioritisation might look like for biggest bang for buck, whether that's quality, safety, performance or finance. I think there's something here about the capacity of the system to deliver that scale of ambition. Across partners, there will be interrelationships and consequences across the partnerships here. So I think there's something in the visibility and the maintaining that connectedness between partners as we take the priorities forward, so we each understand our roles within that. The second point I would make around capacity is there is a natural tendency towards those big programs of transformation, the clinical reconfigurations or recovery work. I really like some of the commissioning intentions around what I would call commissioning for success. So services that are currently being delivered in current places that have unwarranted variation, having a stronger commissioning framework that's very clear as to the standard of service, the service specification and the outcomes that are being commissioned to inform things like IAGs and performance reviews. there is, like I said, there's a tendency towards the bigger transformations, but actually all the evidence in Girth Model Hospital, there is a lot to go at in the current service configuration, and I really welcome that approach, Chair.
Thank you, Chair. And it was just really to, I suppose, to thank Craig. I think I agree, it's a really good document, and Craig and his team have engaged well with the trusts. I really liked on page 17 about the autism and autism assessment and the whole neuro development pathway. And I think as provider and commissioner, we've worked well in this space, and I think it's really good to see that commitment. It's not necessarily seen nationally, and we know that some of these are our longest waiting assessments, so it's just really pleased to see that in the document. Thanks, Craig.
Thank you, Chair. Yes, so I think the ambitions are great, and honestly wouldn't get any pushback from any Director of Adult Services. That's what we want as well. There's none of us want to see people staying in hospital longer than they need to, or anybody going into hospital who doesn't need to. I think it just reiterate that point about it's us doing this together, isn't it, Craig? Absolutely working together. But I think there's just something about recognising that the principles of what we want to achieve are what we absolutely do need to be doing consistently, but how we do those in different places will be different, because actually the needs of populations are different and the environments and the geographies are very different. So I just think there just needs to be some recognition of that. And also, I know certainly in the area I'm the director in, we've got some big ambitions and priorities that are underway, working really closely with NHS colleagues, and that will be the same for Blackburn with Darwin, it will be the same for Lancashire. So it's that we don't need to start afresh here. There are already pieces of work that are underway, and I suppose it's just that real desire to be a mature system whereby it doesn't actually matter which organisation who's doing the leading. It's more a case of it being the best person to do the leading. So again, yeah, that commitment there, Craig, to work together.
Thanks, Chair. Yeah, just to echo really what people have said, Craig. As I read through this, it felt like a commissioning for change kind of document, in the way that Sam described before about not just moving money from one place to another, but actually looking at ways in which we can transform things. And particularly what jumped out to me was the real sense of investing in prevention. So obviously music to my ears. I just wanted to pick up on a few things as well, because there is a section on commissioning with the VCFSE. Very welcome, that recognition of the expertise within the sector, particularly around us having those relationships with people who are furthest away from health equity, I suppose. So that acknowledgement that in order to level up, in order to address health inequalities, then absolutely working in partnership with us. And also, you know, it'd be remiss of me if I didn't say that you've mentioned a move towards longer term, more sustainable and stable models of funding with us as a sector, which is absolutely welcome, of course. I think the ambition throughout this is there, but just to pick up on the kind of the detail that Jim raised and Aaron around where we go from here, how we talk about what we're going to do next, I suppose. There are some things happening behind the scenes that I think are absolutely vital to be in this, as we look at how we kind of talk about implementing some of these intentions. You know, the work that's happening around urgent and emergency care, you know, we've got really clear intentions to do things differently with the voluntary sector in particular. Can we tease some of that out, and can we really address some of that in terms of what does that mean? How is that going to meet the ambitions within this that will really obviously make a difference? And it's really tangible things that we can talk about. And finally, I just wanted to pick up on something that just to me seemed to be particularly at odds with the ambition. On page 17, under mental health, promising that all young people who need specialist care can access it by 2028-29. Now, I understand that that is a promise to young people, but to me that just seems way too far away. So I just really wanted to say that I find that, you know, just completely at odds with the rest of the ambition in this document. I have a 14-year-old who in 2029 will still be a child, and that just really jumped out at me as that can't be a promise we're making to young people at the moment, because they're going to be, you know, adults by that time.
Thank you. I was just coming back particularly with Jim's point about primary care and who's involved in managing frailty. Frailty is one of the most common causes for patients to be admitted into our hospitals. And if you go to primary care, and when we're younger, we might go with problem A or problem B. And often you don't need to see a general practitioner. You can see a nurse, you can see a pharmacist. There are other people you can see, and there are protocols for managing problem A and problem B. Now, when you've got frailty, you've got diabetes and lung disease and heart disease, and you've got a touch of dementia, and actually you've got loads of problems, and there aren't any protocols for those patients. And that's when you need to see a GP, because they can manage those and try and proactively keep those people out of hospital. And that's why, through some of this work that Craig's set out, there's some incentives for primary care to start setting out a frailty register and understanding the needs of these patients in particular. Thanks.
Thank you very much. And again, supportive of this. I just wanted to emphasise and build on a couple of points. Firstly, in respect of Aaron's point, that whole system approach is going to be really important, and we've just been having some conversations about how we need to work together at the appropriate junctures. I mean, clearly there's some parts which local government have no sort of professionalism to support the commissioning arrangements, but there are others in the community and the wider issues where absolutely we need to shape those intentions together. I also wanted to build on some of the comments that Tracy made, and in particular give a shout out for our children and young people whom we often overlook in our conversations, but actually the numbers of children presenting in local government needing support is rising exponentially. There are a number of social factors which contribute to that, as well as medical factors. But actually, if we really want to think about, I hate using these terms, cost avoidance or promoting independence, I think is the terminology we should be using. Actually, we need to be looking at these children right in their very early years. So from maternity through their early years, hopefully preschool, to help avoid some of those issues. So I just wonder, given the fact that collectively we haven't perhaps had the emphasis on children, whether we think we've got the balance of this right in the commissioning strategy. Thank you.
It was just to respond really, because I completely agree, Angie, and actually, and it is, I think the summary document is excellent. In the supplementary document, there's actually quite a lot on all of our intentions for both maternity and children, and quite a lot of the learning disability and autism intentions are also linked to children as well as adults. So it's a valid point, but I think it's in there. It maybe just hasn't come out strongly in the summary document as what's going on in the background. And we did at the last board meeting agree to have a focused board agenda item, didn't we, on children and young people in the future, which Deborah and I just need to schedule in, because I completely agree with you, particularly children. It's all children, but we know we've got some particular challenges across the SEND pathways, and we are doing everything we can in the background. We've had a lot of focus at Quality Committee on those pathways. There are many, many challenges for both local government and health on those pathways. But so I think a focused session at the board on that and on the work we are trying to do together in the background would be really, really helpful.
Okay, that's welcome, Sarah. Thank you so much for those comments. Sam, just indicated present.
Thank you, Chair. So I guess it was just really to say, obviously Craig and I are working really closely together on this agenda, and on page 5 of the document there are some boxes on there in green, you can't miss them, but they are actually really important boxes, because we started talking about these at the start of the, well, so a good few months ago now, at the start of the process, around how do we make sure we try and simplify this for people, we bring it into business as usual, because when we're talking about articulating and now getting some really proper data behind this, some proper metrics, and looking at this from a recovery perspective, this needs to be tied together with the commissioning work, and that's what we're working on at the moment, to say how do we engage the right partners in the right place, make sure things like the assurance meetings and the governance are playing into this. So there will be things coming back as part of the recovery arrangements that will explain this. But I think what we've started with is what is the clear strategy, what are we trying to achieve, then what are the recovery plans to help us to do that, but then what do the commissioning intentions need to look like. Where we've not got to yet is the very detailed articulation of some of the metrics and some of the deliverables, and that has got to be the next piece of the work that we then hold to account through the recovery process. So it's almost working hand in hand, but it needs to be streamlined and it needs to be BAU. So for example, when we're talking about recovery going forwards and place having a really clear role in that, including voluntary sector, and we've been talking with Tracy and voluntary sector partners about how do we engage that sector fully into some of the recovery. We have to do that with some very clear metrics and clear deliverables about how is it going to deliver what we've set out in the commissioning intentions. And that's why the two are really very interlinked. And what you'll also see in there, and I think is a really important part of this, is the OD strategy to underpin it all, because without that, you know, we can have the best plans in the world, but the key to this is going to be working together, and I think that will really help. So we're just giving some real thought. So I suppose it's just that we can't bring that back today to say this is how it's all going to look, but we're trying to keep it simple, business as usual, over 3 to 5 years, not looking at this as being any sort of cost shunting or cost cutting, but actually to do this in a very planned way and to make sense to people. So it's just really to tie that together.
Thank you so much, Sam. Okay, I commented early on, obviously, the ambitions here and the timescales, and I think, you know, really important, and other people have alluded to that in their comments. But there's something in the paper that I picked up on about the prioritisation process that we've got to go through. You know, we've got to go through that and look at that and come back to the board with that. So I think that's really important. And the alignment, I think, of those priorities in place as well. And that's been also indicated by colleagues in the comments this afternoon to you, Craig. So I know there's still some work to do, but I just think, you know, this is a great start. I know, a really good start, and a good paper. I think it's well received by the board. So obviously there are some comments there I think you perhaps wish to pick up on, but thank you for bringing it forward for us.
Thank you, Chair, and thank you for everyone for the comments. And I always find we do a piece of work, everybody wants the next piece of work almost immediately, which I do take on board, and we've already been working on that in the background. So just on your comments, Chair, about delivery in the first year, I can say what we would want to see is improvements in our UEC pathway, and I don't just mean the front door and A&E, I mean the whole pathway. I think we have to see those improvements to deliver some different outcomes for us. We've already talked about primary care, and thank you for David. Mental health out of area placements, that's absolutely a priority for this year. Our NWAS turnaround, and waiting for and less conveyance and more appropriate hear and see and treat and see, and also the work we're doing jointly that Kath's alluded to, as is Aaron and others, on those people who shouldn't be in hospital and how we move them, so the flow agenda. So they're the things that I think absolutely are going to be prioritised in year one. The delivery plan is drafted just on the prioritisation framework. We've taken 2/3 probably of all of our priorities all the way through the prioritisation framework. It's going to generate, as Sarah alluded to before, more work in relation to understanding impact assessments, but that's already underway. For those that are keen to see that detail, it will come to our internal governance in committee form in May, and then it will come back to the board chair thereafter, and that will detail that full plan that people are wanting to see, the who, the what, the when, and how, what the measures are going to be for success. So I am confident, and it would remiss me not to say thank you to Carl Ashworth, who's held the pen on this, who I've probably driven insane over the period of time because I've asked for things a million times in different formats, but I think when you see the final bit of the piece of the puzzle, which is the integrated delivery plan, I think that will give the confidence, and that's what all of our staff will need to be aligned to deliver their priorities, because that's the link through. With regards to primary care, we're doing an awful lot of work on the quality contract element. So again, that's something that I think we should bring back to board. It's going to primary care committee. If Deborah was here, she'd be able to describe the work we've done. And the places, I think that's a really important point, and I really like Kath's, the standardisation comment, but some of that unique delivery will be specific to places. So the ability to retain that identity but having some standardisation, that absolutely links to the work Sam's leading on recovery, and we're dovetailing Sam's team and my team's almost a merged team because they work in a sort of symbiotic relationship. I think the capacity point that Aaron raised, and I really liked Aaron's commissioning for success, and I think I've put it somewhere in the document because I think it's important that we are commissioning for success. And I was really keen, and Sarah drove this as well, that LD&A had a prime spot because we know it's not necessarily nationally recognised, and we think that's wrong. So, and just with regards to, I just need to check, Tracy, because I think those comments you made are really important, but where it talks about children having access to specialist care, and I think there's a very prescriptive set of services that they must have access to by a point in time, which is a part of the national standard. But if it is, we need to say that, because otherwise it just looks like our ambition is 28, 29, and I think I'll just do some work in the background to make sure that that's referenced properly. I don't want to be quoted until someone says to me, yeah, that is the case, but I'm almost sure that's a part of the national ask rather than something specifically we've put in, but I will come back to board on that, and I agree with Angie's comments as well. So thank you for all of that positive feedback. It's been a labour of love, shall we say, to this development of the document, so I do appreciate all of your constructive comments, because I think the document, I'm hoping people have seen, it's changed radically since we very first saw quite a raw set of commission intentions to where we are now. So thanks everybody for your input.
Thanks once again to you, Craig, and the team, for the work that you've done there. And as you say, it's really a huge amount of work. But please pass on our thanks to the boards back to the team for that. Okay, colleagues, we're asked to approve then those commissioning intentions. Are we happy to do that? Yes. Okay, thank you so much. So I shall move us back. Which is any other business. I've not had any indicated, so I don't think there's anything that's going to come forward. Items for the risk register. Anything that we think needs to go on the register? I don't think there's anything I particularly picked up on. No? Okay. So just closing remarks from me. Just like to say thank you so much to the members of the public who've attended today. I hope you found our conversations and discussions interesting. And we welcome you as always to our meetings. We appreciate the time that you've taken to come along, and we do thank you for that. And as I say, please take away our thanks to your colleagues, for you coming here today. It's been a busy agenda, quite busy. I did say it was truncated at the beginning. It was. It's usually smaller than it is, but we've had some great discussions, and I appreciate everyone's involvement in that. So it just remains me to say thank you very much again for your attendance and your contributions to those discussions. And the next meeting is on the 15th of May in this particular room from 1 p.m. till 4 p.m. Thanks once again. I'll close the meeting.
Thank you.
Thanks, Chair.